Good evening, everyone. So, we'll start the class right now. Many of the aspirants will be joining us soon, though. Today's topic is endocrine disorders, and the speaker that we have here is Dr. Avishek Roy, who is an associate consultant ICU in Apollo Multispeciality Hospital, Kolkata. Hello, sir. So, you can share your PPT and start the class. Thank you.
I'll be starting today's discussion. So today's class is on endocrinology, and I'll be covering it over the span of next say 2 to 3 classes. So today's topic is based on sugar control in ICU, broadly based on the sugar control, the level of how we manage sugar in ICU, and along with that, the management of diabetic emergencies. So I'll start right off. So, so first coming to the thing that what is dysglycemia that we face in critical care, that we face a lot of variations in our blood sugar levels. The pathogenesis underlying is multifactorial, so it could be because of the underlying stress, the disease process, the sepsis, multifactorial causes. So it causes of wide fluctuations of blood sugar levels. So the dysglycemia in critical care itself is associated with worse outcomes. Next is we'll discuss about the use of HbA1c and then the evidence supporting the whatever we are telling. What are the glucose monitoring in ICU? Management of diabetic emergencies, namely hypoglycemia, DKA, and HHS, and some question answers. So coming to the first thing first, what is the current definition of diabetes? So it's if it is single HbA1c value of more than 6.5%, the test should be performed in a laboratory using a method that is standardized and National Glycohemoglobin Standardization Program. Fasting plasma sugars should be more than 126, that is the fasting levels. And fasting is defined as no food for at least 8 hours. And after a 2-hour meal, that is a 75 grams of oral glucose tolerance test. That's a standardized thing. So if the sugars are more than 200, then we call it diabetic. And if the patient at a very random sugar levels more than 200 with sign symptoms of hyperglycemia, we can mark them as diabetes. So that's the latest definition we should all be aware about. Now, coming to hyperglycemia and hypoglycemia, so any blood sugar level more than 200 is clinically significant because this is associated with increased risk of infections. It is also causes mitochondrial dysfunction by creating lots of reactive oxygen species. It increases the ICU length of stay. It is also associated with increased ICU acquired weakness. So that's why our glucose control in a reasonable range is important. It reduces the neutrophil elastase activity and the neutrophil chemotaxis, and along with that also reduces the phagocytic action of different different cells like macrophage as well, leading to the increased risk of infections. So similarly, when you have hypoglycemia, when your blood sugar levels less than 55 generally, so that's it can be the definition of hypoglycemia varies in adults. If it is generally is marked as less than 54, some book says 55 milligram per deciliters without symptoms, or less than 70 with symptoms. So this is the current definition of hypoglycemia. However, in the ICU, the patients are often obtunded. They have multifactorial reasons for getting admitted. They might be having sepsis. They might be intubated. So they might be having encephalopathy. So the assessment of a patient's sensorium or signs of per se hypoglycemia is very much difficult. So in that case, less than 70 is taken as a universal definition of hypoglycemia. Why hypoglycemia is dangerous? Because it can cause neural damage. It increases the heart rate. It causes a sympathetic stimulation, causing increased perspiration, increased blood pressure, and also in the prolonged stage, it can cause seizures. When seizures occur, it mostly indicates some form of neural damage, which call it neuroglycopenic manifestations. So, in terms of an ICU patient, hypoglycemia is generally more damaging as compared to hyperglycemia because of the neurological manifestations. Other than the hypo and hyperglycemia, the variation of sugars during the ICU stay, which is measured by something known as COV, coefficient of variance. Supposedly on day one, the patient has a sugar level of 88, and on day two, you find sugars of 300. So it's not that neither 80 is hypoglycemia nor 300 is very high sugars, but this huge variation in the sugar levels causes a damage of the internal milieu of our body in terms of fighting the bacterial infections as well as the overall osmolarity of our system, and also damages the kind of overall electrolyte fluid balance. So the glycemic variability itself is associated with
Silence.
and the other thing that is important is TITR, time in the target range. So supposedly we want to keep a particular set of target for our sugar control, say 140 to 180 or 140 to 200. Now, if you keep the numerator is how many amount of times that you have checked the sugars and the sugars were between the level divided by how many times it was actually checked. This percentage is called as the TITR. So it should be in the range of somewhere between 65 to 70%. I've not mentioned this in this slide, but it should be between 65 to 70%. So 70% of the times, your blood sugar level should be bang on between the target levels. If you're away from that, your patient is going to get hurt. So these are all the variations of sugar management that we have to take into account. What is stress hyperglycemia? Many a times patients who are non-diabetic gets admitted to ICU. On day one, patient sugars are through the roof, probably 200, 300s. And the patient relative says he's never been hyperglycemic in his life. So in that case, what happens is because of the acute stressful reaction, because of the sepsis, because of the steroid hormones and the ADH, along with the different cortisols and growth hormones, and the disbalance between insulin and the other gluconergic hormones, there is increased amounts of blood sugar since. But this is not diabetes. Diabetes is defined as when you have some form of beta cell dysfunction of the pancreas. So to differentiate between the two, we can use an HbA1c. Whenever a diabetic patient gets admitted, always send at baseline HbA1c. HbA1c is an average marker of the glycemic control over the last 3 months. So it does not depend on your recent sugar levels. If your sugar levels have been controlled over the last 3 months, it will be normal. If it be high, if it is uncontrolled, it will be low if it is associated with hypoglycemia. So a normal HbA1c but raised blood sugar indicates the patient is having a stress hyperglycemia. A not elevated HbA1c, high sugars, the patient is non-diabetic. Along with there is a degree of something called as dysglycemia. So whenever a patient in ICU is undergoing some high sugar levels, use the term dysglycemia as compared to other terms like hyperglycemia or diabetes. So HbA1c guided sugar levels can help us to guide what could be the target sugar levels for this patient. So there is this formula that is ADAG, HbA1c derived average glucose. So this formula you don't have to mug up, just for the sake of information I put there. So if you put this, substitute this, you'll get an idea that this should be the target sugar level in this patient. If your sugar levels are below that or above that, that means that is either a relative hypoglycemia or a relative hyperglycemia or the stress hyperglycemia that which I just spoke about. So this glycemia and admission divided upon the mean glycemia, which is derived from the HbA1c, this gives us the stress hyperglycemia ratio, which is again a marker of sugar control in our ICU. And the current sugar minus the expected sugar as per the HbA1c is known as the glycemic cap. So again, I'll just revise it quickly. So there are few terminologies which might be new to a few of the the aspirants. Other than hypo and hyperglycemia definition, we have to know the glycemic variability, which is the overall change of sugar levels, the time in the target range, the amount of the time sugars are within target over the denominator, that is the number of times it has been checked, usually should be 70%. Stress hyperglycemia is hyperglycemia noted first time in the ICU without a background of diabetes. Usually it is differentiated from a diabetic patient by virtue of HbA1c. And there are terms like ADAG, SHR, and glycemic gap, which are also important, which are parameters of sugar control. Coming to the insulin therapy, what are the types of insulin therapy? So insulin therapy, I have mentioned it a bit in later on the slides also. So as I was speaking, so I'll discuss on insulin therapy in the coming slides. Now this is the pathophysiology of a stress hyperglycemia. Whenever a patient is undergoing stress, any patient in ICU, even if admitted for very minute to minute reasons, they undergo extreme amounts of physical stress. So that leads to the release of corticotrophic releasing hormone from the hypothalamus, and that stimulates the pituitary, and subsequently pituitary secretes ACTH, and from there on the adrenal gland secretes the cortisol. And then again, the pituitary and other organ systems, they secrete lot of pro-inflammatory molecules like interleukin 1, interleukin 6, which are also the cause of raised sugar levels because it's secondary to cortisol levels. The end of the epinephrine and the norepinephrine, which is normally secreted under stress response, they're also glycemic. They increase the blood sugar levels because of increased glycogenolysis. So the combination of all the factors like cortisol, epinephrine, norepinephrine getting increased, along with a relative insulin resistance that is seen in these cases, all these things culminate in a higher sugar levels. Now, how does the HbA1c kind of help us in management in our patients? Other than the fact that it gives us an idea that this is the target sugar levels in this patient, if a patient's HbA1c is, say, normal, say somewhere between 6.5 to 8, it means the patient had a tight sugar control, and we can go ahead with a tight sugar control in the ICU also. Tight doesn't mean that it should be very low. It means that we have to keep it between 140 to 180 or 140 to 200. We should not allow the sugar levels to go beyond 200. However, if the patient's HbA1c levels was more than 7%, or uncontrolled sugar, say 9% or 10%, you can keep the patient's sugar levels a bit higher, and that would be less damaging as compared to a tighter control. So, meaning if a diabetic patient with HbA1c of 9 having a sugar level of say 220, probably I'll not give insulin to the patient. I just let it be because that's the usual sugar levels that the patient is accustomed to. So HbA1c helps us in determining the amount, the strategy that we're going to follow, whether it's going to be a more stringent strategy versus a strategy known as permissive glycemia. So permissive glycemia concept I'll be telling afterwards. Now coming to the next part of our discussion is what should be our target sugars when we manage a patient in ICU. So ICU, there is a lot of variation as to the. I'll just complete the previous part once, that the type of insulin and all those type of insulin I'll be discussing a bit later. So insulin is usually given subcutaneously, but we can give intravenous. And why we prefer intravenous in a patient who has a very high sugar levels is because in critically ill patients who are on ventilator, on multiple vasopressor infusion, the peripheral perfusion is poor, so subcutaneous absorption is kind of dismal. So in this case, it is preferable to give an IV infusion. And usually when you give an IV infusion, you monitor more frequently. Usually that's somewhere between 1 to 4 hour interval. Again, the discussion will be coming afterwards. Now, what should be the target sugar levels? Now, for the sake of exams, we have to know one or three or four names of major trials that paved our path in terms of the determining the target sugar levels. The initial trials were in the year of 2000s, early 2000s, where there was this Leuven surgical trial. It's a place in Belgium where Vanderburg et al. Did a trial on around about 1600 patients who were requiring mechanical ventilation, and they divided patients in two groups. One having a tighter sugar control, that is 80 to 110, and one having a liberal sugar control, 180 to 200. And what they showed is that the mortality and the risk of infection was significantly high in the patients with liberal group, means patients with in whom the sugar levels were kept higher, they had bad outcomes. So this raised eyebrows for many intensivists, and then came the date. There was a time when they started really rigorously keeping sugar levels to a lower limit. But there were many drawbacks to this trial. One is that it was a pure surgical trial. So patients who are post-surgical unit, it was done. And if you go through the methodology, you will find that multiple loopholes. Many patients were given IV dextrose, some patients were given oral along with some TPN. So there was a huge variety of variability in terms of the methodology, not kind of a standardized trial that you will want to quote while targeting your or depend or deciding upon your sugar control. Next came a medical ICU trial on the same center on 1200 odd patients, which target, and the comparison was also same, 80 to 100 versus 180 to 200. But there they found that there was no difference in primary and secondary outcomes. And intensive insulin therapy, IIT Stanford intensive insulin therapy associated with increased incidence of serious hypoglycemia. However, the in-hospital mortality was better with intensive insulin therapy despite having higher incidence of hypoglycemia, and they favored that they favored they gave a verdict in favor of intensive insulin therapy. This led to a lot of confusion. Now intensivists were running around the hospitals with insulin syringe and charts, running behind the nursing staff to have a tighter sugar control. That brought forth two major trials. One is YSIP, which was a 2:2 factorial trial, where they actually compared the use of starch versus crystalloids and intensive versus a liberal kind of sugar management strategy. And they found out that in those patients, between the two strategies, there was no significant difference in terms of mortality, and there was higher incidence of hypoglycemia, severe hypoglycemia, and seizures in intensive insulin therapy. Now, this is the first trial which showed a path that the whatever the previous trial showed probably isn't that much true. And then came the biggest trial regarding this topic. I want everyone to know at least one trial. If one trial is asked about sugar management strategy in ICU, what is the quoted trial? That's a nice sugar trial. It took over 6,000 patients that were included in the trial. It was a multicentric trial. So previous trials, most of them were unicentric. When you take patients from all over ICUs, you are actually doing a pragmatic trial. You are considering different variation of practices as well. And the primary outcome, they took a 90-day mortality, which is also a very good outcome measure, and they showed that the intensive therapy group had increased chance of mortality and increased deaths of cardiovascular cause and there was obviously more cost involved because you're measuring more frequently sugars more frequently, the risk of hypoglycemia etc is more frequently, and there was no huge difference in terms of any of the effect. And they said that the sugar control should not be that much tight, it should be liberal, somewhere between 140 to 180, and that kind of eased the life of our current intensivist as well. So this is the landmark trial which is has to be quoted, the best trial till date on this topic. Now, after that, there are another two trial came, the glue control call, which also showed in around 1,000 patients. That was an RCT which showed that the intensive insulin therapy associated with more chance of hypoglycemia. It was stopped early because of the futility of the trial itself. And the surprisingly, the Vanderburg, who first devised these trials, the Leuven surgical and the MICU trial, they came up with an updated trial on their own with 9,000 patients in their 2023, published in INDIGEM, and they found out that an intensive versus liberal, so they did not compare between an intensive 80 to 110 versus standard, that's 140 to 200. They compared intensive versus liberal, that is more than 215, is using some logic insulin algorithm, which is basically some AI based algorithm, and they compared length of stay, ventilator free days, everything were same. But in this trial, surprisingly, despite this tighter sugar control, the incidence of hypoglycemia is only 0.7% or less than 1% in these patients, which is surprisingly low. The cause, after analysis, people could only say that probably the nursing staff were more agile, more workaholic. But to keep a patient sugar between 80 to 110 consecutively, you will risk the patient having more risk of hypoglycemia. So the trial demonstrates that the equal safety of both the strategy. And now comes a newer concept that argues the modest permissive hyperglycemia. That's probably a sugar level till 250 is safer, and as compared to normoglycemia. And the intensive insulin therapy, the tighter sugar control is now out of the book. So to summarize, our current recommendation is to keep a sugar levels between 140 to 200 or 140 to 180. Both are acceptable. Even there are trials which are saying that a less tighter control till say up till 240 or 250, especially in diabetic patient, is acceptable. Don't beat your head out if your sugar levels are 240. It's not going against the management. However, if your sugar levels are below 140, especially below 100, somewhere between 80 to 100, and you think that no, patient is not having hypoglycemia, this patient is bound to get hypoglycemia when you're not monitoring. And you are monitoring at least hourly interval. There will be episodes in between an hour where the patient will have hypoglycemia. Therefore, do not follow the intensive insulin therapy. Target 140 to 200 for the time being, and less liberal strategy or a bit more liberal strategy is more welcome. What are the methods of glucose monitoring? Generally, we go by the capillary blood sugar method, but as usual in every ICU patients, there is risk of sorry less perfusion because of vasopressor requirement. Patient may have significant edema. So all these things leads to significant amount of error, and the amount of error can rise up till as much as 30 to 40%. So your sugar levels might be 40, but the actual sugar levels might be somewhere between the 60 to 70, which makes a huge difference. And that's why checking the blood sugar levels or checking by the arterial or the venous blood sampling is always preferable. Between a VBG and ABG, there is not much of a difference. You can check either the VBG or the ABG. What I mean by ABG and VBG is not particularly blood gas analysis. You can take a sample from the arterial line and check in the glucometer. That is also acceptable. If you have a proper co-oximeter in your ICU, which analyzes the ABG, the co-oximeter levels are much more accurate as compared to blood sugar, which is shown on the glucometer. So, if your patient is having a blood glucometer levels of 90 and your ABG, which is normally calibrated showing a blood sugar of 65, it is the ABG which is more accurate and not the capillary blood sugar. Do not cross check your values in the ABG with the capillary blood sugar. There is a phenomenon known as leukocyte larceny. If you have increased amounts of leukocytes in your blood, for example, hyperleukocytosis from acute myelocytic leukemia, myeloblastic leukemia, or hyperviscosity syndrome from other causes, you might have a falsely low blood sugar levels because all the leukocytes they end up eating or taking the glucose. So in those cases, there are some precautions to be taken. I'm not going into the details, but this is one phenomenon you need to be worried about. And the other method that has come up is continuous glucose monitoring. So rather than pricking the patient or checking repeatedly and bothering the nursing staff, there are sensors, glucose sensors, subcutaneous glucose sensors, which take sample from it based on microdialysis principle, which take sample at the interval of 15 to 20 minutes, and any fluid can be used, for calibration purpose. Generally, it is safe. It is used, although it is called continuous. It's a misnomer. It checks at the interval of 15 minutes, as I said, but nonetheless, it is much more less labor intensive and more frequent as compared to what normally we practice. Drugs like paracetamol, dopamine, and mannitol they interfere with the readings of this technique. So not much in vogue. I don't think CGM can be asked in a question, but just to remember what are the techniques, CGM or continuous glucose monitoring is a newcomer technique. And there is closed loop monitoring, AI based thing, where you have a particular sugar level. Based on that, you have an algorithm put forward, and then the insulin is automatically adjusted or reduced based on the sugar levels. Now, coming to the emergencies of the sugar control. So, coming to the first emergency, most common that we see in the ICU and most dreadful is hypoglycemia. Most commonly, it is we have to first check whether the patient has received any form of insulin, mismatch insulin, extra insulin, lack of feeding, and but simultaneously we are giving insulin. All these leads to hypoglycemia. In community, an acute alcohol binge also causes a reactionary hypoglycemia. When alcohol is taken in a large amount, it causes a reactive hypoglycemia because of the release of insulin. There is a reflex which is involved in that. There are different drugs, oral hypoglycemic drugs like sulfonylureas, and some antibiotics like pentamidine, fluoroquinolones, especially levofloxacin in elderly patients, and some of the antimalarials like quinine, chloroquine, and artemisinin. These are all known to cause hypoglycemia, and non-selective beta blockers. This cause hypoglycemia. Recurrent hypoglycemia, if you are facing in a patient, you should always think about three possibilities. One is sepsis. That is, the patient has a very low glycogen reserve, patient has been eaten, and the infection is causing a derangement of the glucose metabolism. Other possibilities is a myxedema coma. Other than that, an acute liver failure, acute on chronic liver disease, severe acute kidney injury where your AKI per se does not cause hypoglycemia, but AKI can cause accumulation of different hypoglycemic agents, and that can itself precipitate hypoglycemia, and critical illness related cortisol insufficiency, CIRSE. CIRSE I will be discussing in the next part of the, next class. So when you grossly again to summarize, the causes of hypoglycemia in ICU more or less is insulin overdose or relative overdose, lack of feeding in a patient, starvation, and sepsis, infection. These are the most common causes. If these three are not there, always look out for a steroids insufficiency, that is SIRSI, in a critically ill patients. Rare causes can be there, like insulinoma and all, but in an ICU patient, suddenly insulinoma won't bother you. So investigation of choice in an hypoglycemic patient, generally we manage first, send investigations later. If you want to send, you can send an insulin, a C-peptide levels, ketone levels, and LFTs. How would ketone levels help us? If ketones is positive, that means the fatty acid is breaking down. On the background of hypoglycemia, it's mostly indicates starvation ketosis. LFTs help in differentiating or diagnosing acute liver failure. Now, one interesting finding: insulin is released from the pancreatic beta cells. C-peptide is also released from the similar type of cells. Both are kind of brothers to each other. So, if your insulin level goes up, C-peptide level should also go up naturally. So, if insulin level goes up, C-peptide goes up. That means the patient is having endogenous insulin, which is secreting in a higher amount, probably an insulinoma. But if your insulin level is up in the body, but C-peptide levels are suppressed, you should suspect exogenous insulin, and you will not be surprised to know that there has been cases where uh, purposeful or accidental administration of insulin exogenously has led to severe hypoglycemic seizures in patients, especially in pediatrics. The parents come, they exogenous administered insulin when nobody is looking at them, and the patients keep on getting low sugars and seizures. Then actually by looking at it, by suspicion, looking at the C-peptide, and then afterwards analysis by CCTV footage, you find out that the parents are actually causing it. So we have to always think about outside of the box in some cases. This I have taken from the MCRIT site. That what is the general management of hypoglycemia? So the hypoglycemic dose of dextrose is 0.25 to zero point 0.5 grams per kg body weight of dextrose. So it's 0.25 to zero point 0.5 grams. So if you're using a 25% dextrose, use it 100 ml. So 60 kg body weight, generally the sugar needed comes somewhere between 20 to 30 grams. So if you are using a 25% dextrose, give 100 ml bolus. If you are using a 50% dextrose, give a 50 ml bolus. Both of which gives 25 grams of dextrose. So there is a formulation for how much it is. It's generally in the range of one sugar levels. I think equates to three amounts of dextrose, something like that. Some equation is there. Don't remember it right now, but it should be 25 grams of absolute grams of dextrose that should be given. If the patient is able to take orally, you give some feeding, or if the patient has an RT in situ, give some feeding immediately. If you don't have an IV access, at least give dextrose via the RT. That's a smart solution. And you can give dextrose in an emergency in an intra-arterial route also. This I'm telling you off the board record. You can give it intra-arterial in an emergency, but definitely not to be advocated routinely. Again, now the what should be the maintenance amount of the fluids? So maintenance fluid requirement is IV dextrose D5 or D10 at a higher rate, 75 to 150 ml per hour. If your patient is requiring fluids, you can run D5 infusion after you have found the patient hypoglycemic. And that is especially important in patients who are septic, having liver failure, so as to prevent recurrent hypoglycemia. So if a patient has developed hypoglycemia, say 40 at 7 p.m., you gave a 25% dextrose, don't sit back for another sugar fault in the night. Just run an infusion till the sugar levels are normalizing, and till that time, let's find out what is the causative cause behind the hypoglycemia. Now, if the patient is having a fluid overloaded state, or the patient is having a euvolemic state where you don't want to purge too much amount of fluids, you can use a 25 or 50% dextrose infusion, but preferably you need a external jugular line or or a central venous catheter for that purpose, because 25-50% dextrose on the in the form of infusion can damage your veins. Next is that if you are having recurrent hypoglycemia, think about a steroid insufficiency. Do not wait for your lab results to come back positive for a reduced cortisol. If you have a suspicion, start steroids therefore. So the dose is 100 mg Q6 hourly. And if you are still finding that recurrent hypoglycemia is there, you can use octreotide as a fallback option. Octreotide is useful for recurrent hypoglycemia of any cause, as well as if there is an insulinoma. It reduces the insulin secretion from the pancreatic beta cells. And ultimately, you have to find the cause and come to a final, you have to basically treat the cause. And one approach is using glucagon. that was previously taught in during my MBBS. That's glucagon 0.5 to 1 mg intramuscularly. But because of the risk of glucagon, the risk of having nausea, vomiting, the risk of hyperglycemia, rebound hyperglycemia, and when the glucagon effects comes back, goes up, goes away, then you can have rebound hypoglycemia as well. Glucagon is not a preferred option nowadays. If you don't have anything in the hospital, you can give an intramuscular glucagon. And if you don't have an IV access, don't forget that you have a intraoral access can be a useful option. We often forget that intraoral accesses are not there. I mean, we go directly for a central venous access or oral. Intraoral should be used. Now, coming to the important parts of the other diabetic emergencies, that is the DK and the HHS. And the maximum questions that you can get from the out of the entire discussion is from this section. So I suppose that everyone of you has read sometimes in your life on DK and HHS, and you might be well versed with the general discussion or general concepts. So I'll be discussing few intricate concepts about the management of DK and HHS and the current updates or what newer things that we need to think about. So we know that the mortality, so the DK HHS, DK stands for diabetic ketoacidosis, HHS is hyperosmolar, hyperglycemic state. It does previously we used to call it hyperosmolar, hyperoncotic coma or non-ketotic acidosis, non-ketotic coma, different names were called, but nowadays it's called as a hyperosmolar, hyperoncotic, hyperglycemic state. So both of which associated with insulin insufficiency or deficiency, but the mortality is more in HHS. We have to remember this, and but the insulin deficiency is more in DK. So HHS is seen much more in the elderly population. The insulin deficiency is less as compared to DK. DK as compared to an HHS occurs mostly in young adults or adults as well, equal predilection. But if the insulin deficiency is severe and the acidosis is much more severe in DK. Blood sugar levels usually in HHS usually above 800. The definition wise, it is more than 600. That I'll come. That the charts are already there. But usually you won't find a HHS patients with a sugar of 500. However, DKA can occur in the range sugar levels anywhere more than 200. There is an entity known as euglycemic DKA where you can have normal sugars, but the patient will have a acidosis and ketonemia. So I'll discuss euglycemic DKA in 1 or 2 slides. The management goal of DK is to give intravenous fluids, give adequate intravenous insulin. You have to go for the electrolytes control, the hypokalemia, phosphates, everything we have to control. And do not forget that what caused the incident. We have to tackle the underlying cause as well. Whether it's a cardiac event, whether it's pancreatitis, whether it's trauma, we have to obviously address that. Coming to a detailed discussion on DK. So DK is defined as presence of all three of diabetes. That's a mnemonic. That's how you remember. If your blood sugar is that's more than 250. So that's the mnemonic is DKA. So D stands for diabetes, more than 250 sugars. K stands for ketonuria / ketonemia. Ketonemia of more than 3 millimoles per liter of blood, or ketonuria of urine more than 2 plus dipstick. And acidosis defined as pH of less than 7.3 or a bicarbonate of less than 18. In awake patient will always try to compensate acidosis. So pH can be normal in many patients. It's in fact, patients who are kind of stable but having acidotic breathing will have a normal pH, somewhere between 7.35 to 7.4. So look at their bicarbonate and their base deficit to diagnose a DKA. And acidosis here is always high anion gap acidosis, but later on they develop a normal anion gap acidosis during the resolving stage because of the exogenously administered fluids, and if they have a component of acute kidney injury, they can have a normal anion gap acidosis. So the classical teaching DK is high anion gap acidosis at the diagnostic stage. Definitely that should be there, but when you are managing the patient, you can have all sorts of combination of the above. What are the signs of a DKA patient? So probably a diabetic patient coming in any form of emergencies, be it palpitation, be it heart tachycardia, be it obtunded state, acidotic breathing, perspiration, anything that you find, always rule out a DKA. So diabetic patient coming to emergency, you should always rule out a DKA. So signs could be anything. Patient could have an MI, comes to with a DKA, patient is having cardiac arrest. You never know. Or having an hyperkalemic arrest. There is Kushmal breathing, which is a deep hyperosmolar, it's a hyperpnea where you have increased rate, and hyperventilation where you have increased depth of respiration. So you have increased rate as well as increased depth of respiration. Abdominal pain is significantly seen in DKA. Around 30-40% patients can have abdominal pain. What is the cause? Nobody knows exact reason. The proposed causes are probably mesenteric ischemia, probably hypovolemia, and in some cases there would be pancreatitis, which is causing a DKA. And you'll be surprised to know that there are significant percentage of patients who first present with acute pancreatitis and a DKA as a combined. So always send a diapers amylase level in these patients. But again, strangely, as medicine is never 2 plus 2, or 2 plus 2 never occurs 4 in medicine, many of the cases DKA can itself cause a falsely elevated amylase, and 20 up till 25% increase in lipase can also occur. You might have come across a lipase of 300. Don't treat a lipase of 300 as pancreatitis. Don't label it. You should generally see a higher lipase, probably in the range of 600, 700 to diagnose pancreatitis. This phenomena is known as a lipase leak. Again, it's a separate topic. I'll not go into that. So this is the entire clinical conundrum of how a DKA patient presents. The next entity or a sub-entity of DKA is euglycemic decay, where you have normal or near normal sugars, slightly elevated, but not in the typically higher range, but you have all symptoms other than diabetes. That is, the ketonemia is positive and acidosis is positive. It is seen in 2 or 3 conditions. First would be the use of SGLT. Sorry, this is a typing mistake. SGLT2 inhibitors. All the gliflozins, the dapagliflozin, canagliflozin, empagliflozin, all these things can cause a euglycemic decay. Understandably, because SGLT2, they will inhibit the sugar absorption from the renal tubules, obviously leading to glycosuria. So sugars are eliminated through the urine. So your blood sugar levels are lower as compared to other DKA patients, but they will have other signs of and ketonemia. Also, it can be seen in starvation, where your prolonged starvation can cause, along with that, there is a decay precipitation, but the sugars are not that much high. And pregnancy also leads to this, because in pregnancy, there is a natural glycosuria that happens during a management portion. So I'll come to the decay management in details. Now, the first thing is, what is the supportive management? Patient has come to you. Any patient, you should first address the ABC. So it should be supportive. So the oxygenation support should be either an HFNC or NIV, high flow, obviously. Even if the patient is having a normal saturation, but you have to support the acidotic breathing. Otherwise, patient will get tired. And the moment they get tired, they will build up PCO2. Their pH will drop below 7, and they will have cardiac arrest. So you give us respiratory support. Either NIV or HFNC, both are fine. NIV can cause claustrophobia. They can cause gastric distension. DKA patients have a predilection for vomiting because of the acidosis and ketonemia. And we have to also remember that many diabetic patients have diabetic gastroparesis. So they can have decreased, prokinetic movements. They can have vomiting. So avoid NIV. Given high flow nasal cannula, keep the flow around 50 to 60 liters. Avoid intubation as much as possible, because the most common mistake we do, these DKA patients compensate naturally by virtue of hyperventilation with minute ventilation in the range of 15 to 20 liters. We put the patient on a ventilator, we keep minute ventilation of 8 to 10 liters. You induce a state of combined metabolic and respiratory acidosis, landing up in cardiac arrest. So do not try to avoid intubation. If you are going to intubate, be very aware of during the peri-intubation period as well, because peri-intubation we ventilate at hardly 12 to 14 per minute. You have to hyperventilate during the intubation, and post-intubation you have to keep an adequate ventilation by matching with what the patient was originally had. And no bicarbonate during DKA management, not at least in the initial period. Absolutely no bicarbonate unless there is a life-threatening situation like less than 6.9 pH, imminent arrest, like that. So this is the picture of ketone test states. You can, put your urine drops on the ketone sticks, and you can match as to the what is the grade. Usually it should be 2 plus or more. Findings indicate some sort of ketone bodies in the urine. You can mug up that. I'm not going to this. So the difference of DK and HHS, again, I'll just go through it once. So the basic pathophysiology is that, not the difference, is that the gluconeogenesis, because of the unchecked gluconeogenesis, the lack of insulin, that causes high sugar levels. The high sugar levels along with the ketone bodies that are produced. Why is ketone bodies produced? Because of the insulin resistance, your blood sugars or the glucose is not broken down. Rather, the muscle fat or the body fat stores are broken down, causing release of different fatty acid molecules, which are converted to ketone bodies. The namely three ketone bodies: the beta hydroxybutyrate, the acetoacetate, and the acetone. These three main molecules or the ketone bodies. So these ketone bodies, along with the sugars, they cause an osmotic hyperosmolar state that causes, raises the serum osmolarity. It also causes osmotic diuresis because they are hyperosmolar. Once they release they gets eliminated in the urine, they will draw some water along with them, causing dehydration. Ketone bodies also stimulate the emetogenic centers in the brain, causing nausea, further aggravating the dehydration part, nausea and vomiting. And ultimately, the ketone bodies causes a rise in the unmeasured anions in the serum. That's what we call is high anion gap acidosis. So the pathophysiology, this is all what I can tell you. I think there was one slide on the pathophysiology as well. I'm not, if I'm finding it, I'll just briefly go through. So this is what the pathophysiology is. The different conditions leading to decay patients, different as per the data, it could be an infection, could be ischemia, could be a heart attack, could be a surgery, trauma, anything. So this is one mnemonic that is often practiced. You can remember for yourself. The first mnemonic that I taught was DKA: diabetes, ketone positive, and acidosis. Second one, the 6 I's of decay. What are the I's, the precipitating factors of decay? It can be an infection, it could be an ischemia, like it could be a mesenteric ischemia, or it could be myocardial ischemia or infarction. Iatrogenic means you have given steroids, you've given thiazides, or you've given something like a higher dose of thyroid hormone or or sugar itself, I mean dextrose itself, and you have vomited the insulin. It could be intoxication. You have taken some exogenous medicine which has precipitated insulin mist and intra-abdominal process like pancreatitis. Now coming to the diabetic, again the difference between the two, I've already told that. Just to briefly summarize that in DKA having insulin deficiency is much more. Hyperglycemic state has a less insulin deficiency, but the osmolarity is much higher in HHS, the mortality is much more higher, and the fluid requirement is much more higher in HHS. Now coming to the insulin treatment, very, very important. So target, now these are the bullet points to remember during management of DKA. So the target of insulin therapy is not to lower sugars, not to reduce some other markers and all, not to reduce ketone bodies by some method. They're the markers of how well it is acting. So the actual marker is a closure of the anion gap. So if your anion gap is closed, then that is the actual indication that your insulin is working, or that is the target point or end point of insulin therapy. So this you have to remember. The dose varies. You can give a 0.15 units per kg body weight as an infusion at the start, or you can just give a bolus at 0.1 units per kg and run a zero point 0.1 units per kg per hour infusion. Either way, you can continue. You can give the infusion without the bolus itself. Then you have to convert to subcutaneous insulin. Now the patient has come with DKA, you have given enough of fluids. Fluid management I'll come a bit later. Just pardon me for 1 minute. Just I'll attach the charger. Sorry. Sorry for the interruption. So yeah. So as I was saying that when the management starts with giving intravenous fluids and starting an insulin infusion at the rate of 0.1 units per kg per hour. So usually 60 kg man, you start with around 6 units per hour insulin. You monitor the blood sugar levels and preferably blood ketone levels, not urine ketone levels. So when you convert the IV insulin to a subcutaneous insulin, when you should consider is that when your anion gap is closed, patient sugar levels are relatively lower than 200, 250 to 300, and your anion gap is closed. During that time, always switch over from an IV to subcut. How to switch over? You should or give the subcutaneous dose 2 to 4 hours before the IV insulin infusion ends. So if your IV insulin infusion ends IV insulin infusion ends at say 12 p.m., you should give your subcutaneous dose roundabout between 8 to 10 a.m. and then stop the insulin infusion at 12 p.m. and then only then you can avoid a rebound acidosis. So insulin here, the main motor function of insulin is to avoid acidosis or reduce the blood ketones levels. Now, long-acting insulin, the dose varies. It's usually somewhere between 0.2 to zero point 0.3, maximum 0.5 to zero point 0.8 you can be given. So this trick I'll tell you a bit later. Not so much important, but you have to give some long-acting insulin. The important thing to remember is that long-acting insulin can be continued during a DKA management. So we have this thing in our mind, okay, DKA patient comes, we have to give insulin and IV insulin therapy, but long-acting in subcutaneous insulin, you can continue. You don't have to, you can continue over and above the IV insulin. That's what I meant. So you give a 10 units of long-acting insulin, probably a deglutec or a glargine, and you continue the IV insulin therapy as well. Short acting, intermediate acting, those cannot be given. For starting those, you need to have this bridging of the insulin therapy. You monitor serum potassium regularly. The target sugar drop should be 50 to 100 milligram per deciliter per hour. So if your starting sugars are say 450, in your next hour it should be somewhere between 400 to 375. If it is below 350, it is higher drop or excessive drop. If it is say more than 400, it is 425. It's a less than what you expect a drop. So if it is a less than what you expect, we increase the insulin infusion. Simple. But if it is more, you reduce the insulin infusion. But what is the risk of having a more drastic drop of sugar? One complication will be there. I'll be discussing in a bit. So monitor the serum ketones for your management strategy. Do not go for urine ketones. Once you have diagnosed, just forget about the urine ketones. Subcutaneous can be an alternative for non-shocky patients, means patients who are not in vasopressors. You can solely manage a decay on subcutaneous insulin. Again, for exam purpose, it's better to not go into these controversial things. And no role of bicarbonate except for life-threatening emergencies like pH of less than 6.9. So ketones in DKA, there are three: acetoacetate, beta-hydroxybutyrate, and acetone. The main rate-limiting enzymes is HMG coenzyme reductase, and it is estimated by the nitrochloride reaction, that Rotheras test that we checked in the urine test. The beta-hydroxybutyrate requires a special equipment in the blood to be checked, so it's not always available in the lab. So if you don't have a method to estimate the blood ketones levels, don't order a urine ketones. Just monitor the cation gap. If your anion gap is closed, your acidosis is resolving. At least the decay component is resolving. And potassium in decay has to be kept normal. During the decay diagnosis period without insulin, it's actually higher. It can cause hyperkalemic arrest as well. Once you start therapy with insulin, it reduces drastically. So if your potassium is less than 3.3, it is advisable to hold insulin and give potassium 20 to 30 milliequivalent per hour. Again, from ICU point of view, these are all based on guidelines, JBTS guidelines, ADA guidelines in non-ICU patients. But when you're managing a patient in ICU, you have all kinds of lines and catheters. You put an external jugular line or put a central line, and you manage insulin and potassium simultaneously. Why? Because if you stop insulin during the acute phase of acute management, there will be rebound acidosis. Never stop insulin infusion during the management of decay unless decay is resolved and subcutaneous insulin is given. Otherwise, if you say sugars of 70 but ketones are positive, you have stopped the insulin because sugars were low, and now you find a situation where you again in the morning you say lactates are high, your anion gap is again increased, again you are back to the same scenario. So at this scenario, you can run simultaneous dextrose and insulin infusion, and you can, because in goal of insulin is to reduce the amount of ketones, reduce the acidosis, not managing sugar per se in DKA patients. Sugars will get automatically controlled. So if your patient is having DKA ongoing, but sugars are say lower than normal because you have already given DKA insulin, continue dextrose with insulin. That is point number one. Point number two, for the recent concept that I'm saying, if you're having hypokalemia, treat the hypokalemia aggressively, but continue some form of insulin. At least the low dose should be continued. And the amount of potassium requirement depends on the amount of deficit. So if your potassium is somewhere between 3.3 to 5.3, the deficit is 20 to 30. If it is less than 3.3, it is again 30 or more. And more than 5.3, you don't need a potassium replacement. What is a type of fluid? Generally, we are taught that DKA patients have such 100 or 200 mils per kg of the body fluid deficit. So that amounts to around 6 to 7 liters of fluid in a 60 kg man. In a non-ICU setup, severely dehydrated patient stands true, but supposedly a patient has a heart failure, comes with MI, heart failure, patient has a CKD. Would you give 100 ml per kg of fluid over 24 hours. That means you load the patient with 5 to 6 liters, not that. So your fluid management strategy as per the 21st century ICU should be guided by your dynamic markers. Always check the bedside ultrasound, look at the IVC diameter, look at the echo, and then decide based on the preload responsiveness, and then decide upon your fluid management strategy. So start giving a bolus, but always monitor for fluid overload. Don't just blanket give 6 liters of fluid to the patients. Initial rate would be obviously higher in the range of 150 to 200 ml per hour, but reduce it once your fluid requirement as per the body needs and dynamic parameters goes down. Phosphate generally is not, routine supplementation is not required, but if you're having a patient with respiratory dysfunction, having refeeding syndrome on the background, cardiac dysfunction, or risk of arrhythmias, you can choose to supplement that. You can give a 4 phosphate infusion by giving pot phos infusion, 1.5 ml per hour of infusion. Coming to some discussion on HHS. So HHS requires more of fluids, less of insulin. This I've already discussed. More of mortality and complications. Now in the overall complications of DK and HHS. So as I said, what will happen if your sugar levels are drastically fallen, be more than 100 per milligram per deciliter per hour? You can have cerebral edema, especially in a younger patients. Why? Because your sugar levels are higher throughout. Supposedly sugars were 450 for a few hours. Your brain is accustomed to that sugar levels with high osmolar state. Now suddenly if you drop the sugar in the plasma so to less than 350, your plasma osmolarity reduces, but the brain takes time to accustom. During this time there will be an imbalance between the sugar osmolarity of the plasma and the brain, causing the brain to swell up. It will draw some amount of fluid from the serum and it will cause cerebral edema. Since pediatric patients and young patient adolescents have a lesser amount of cranium size, they tend to have more risk of cerebral edema. And hypernatremia, MCQ, I don't know if it is asked in the MCQ, I have not come across, but hypernatremia is a protective factor here. Naturally, because hypernatremia tends to have higher osmolarity. So even if you reduce your sugar by more than 100, if you have hypernatremia, they will not go into cerebral edema. Then there are other complications like hypokalemia, arrhythmias can occur, hypophosphatemia can occur. This chart here, very important for exam point of view. Just to remember the definition of severe decay. So the diagnosis decay is done by less than 7.3 pH, ketones positive, and mental status generally is alert. But severe decay is defined as arterial pH of less than 7, ketones. This I think this is how this is not mentioned. I don't know. Probably some I took it from source, but it could not get pasted. So ketones more than 3 is mild, 3 to 6 is moderate, more than 6 is severe. This I'll amend it in the slides. I don't know how it's missed. So in the severe, ketones are more than 6 millimoles per liter. Anion gap, it is more than 12, and the patients with severe decay tends to be in comatose state. This is the overall management strategy. So you should start insulin in when you find a decay patients, preferably the IV route, zero point 0.1 units per kg per body weight as bolus, followed by 0.1 IV infusion. You monitor the sugars and monitor the ketones. If you monitor the ketones, the rate of drop should be at the rate of say 0.5 to 1 unit per hour of ketone drop. And in IV fluids, if depending on the fluid status, you can give some amount of fluids. If your sodium levels are higher, then you give hypotonic solutions like half normal saline, 5% dextrose with normal saline. But if your sodium levels are normal or lower, you can give normal saline. One point I missed, sorry, my bad. During gradient fluid therapy, you prefer to give balanced salt solution over normal saline. If I have time, then I will explain this. Otherwise, so there is this concept of strong anion gap. Somebody just give me a reminder at the end of the class. I'll briefly tell about this if I get a time. Why balanced salt solution are preferred. So monitoring, as I said, so you monitor the serum ketones and the serum sugars, and decay is resolved when your anion gap is closed. You can also monitor the ketones if you have the facility. Ketone should be less than 0.6. Less than 1 is also, that is also sufficient. If it is less than 1, that is also appropriate. This I have already discussed. Now coming to a bit discussion on the insulin regimes. So insulin regimes can be of sliding scale. So when the patient is not so much sick, not on vasopressors, you can use subcutaneous insulin at sliding scale. Historically, or rather in the ward, not historically, but in a non-emergency setup, non-ICU setup, you can use glucose insulin potassium drip. So if your patient is having decay or patient is diabetic, for example, any diabetic patient also, GIK drip can be given. I'm wrong in saying that not it is decay. It is a non-diabetic patient. What kind of fluids you can give? So you can give a GIK drip. Supposedly patient is in ward, awaiting for surgery, not taking, taking some food but not adequately. You can give a GIK drip. So it has got sugars, it has got potassium, and it has got insulin. So insulin for the diabetic part, dextrose so that there is no hypoglycemia, and potassium in that fluid so that there is no hypoglycemia. There are various treatment protocols, like there is an Albertis regime which has got 500 ml of 10% dextrose with some potassium and insulin in that same fluid. It's run at some 50 to 100 ml per hour perioperatively. And there is a CMC Velo regime where, based upon the sugar levels, you can titrate your fluid, dextrose and potassium containing fluid and insulin infusion separately. There is a thing known as VRIII, which is known as variable rate insulin infusion regime. This is nothing but the IV insulin infusion regime that we see in ICU. So if you have a patient who has a sugars of more than 300, in a non-DKA patient, I'm saying, the choice of go-to insulin would be an IV insulin, a regular insulin. How will you decide what much amount of sugar to be given? The trick is generally here you will always have some chart to guide you, but if you don't remember it, just remember, divide the sugar value by 150, give initial 150 x by 150, give as bolus, and run an infusion. Supposedly sugar levels are 300, 300 by 150 is 2 units, give 2 units bolus, run 2 units per hour infusion. That's the usual trick. And monitor. Supposedly at 2 units per hour your sugar level still high, so you have to increase the rate to 2 to 4 and subsequently higher than that. And if it is low, then you have to adjust it accordingly. There is three rates, what is reduced, standard, and increased rate. This is also applicable for sliding scale as well. This is based upon the patient's data and the patient's body stature and the insulin requirement. Sorry for the disturbance in the outside of the house. Yeah, so as I was saying, that this rates of requirement depends on the patient's metabolic status as well. So if the patient has a reduced rate, more a cachectic patient, cancer patient, or emaciated patients tends to have lower requirement, whereas patients who are obese and patients on steroids, they will require a higher rate. So this you don't have to remember everything. If you remember that insulin, this 150 trick that I told you, you can use it yourself. What are the types of insulin? Now, this is some bonus things that I've added intentionally in the last part. That what are the types of insulin? Just to go fast through these things, because we have to be conversant with our daily practice. So insulin could be ultra short, short acting, and long acting. Nowadays, we are preferring to divide it based on prandial, means bolus insulin, which is given during or during the meals or just before the meals, and the basal. So basal insulin maintains a steady state of insulin throughout the day, which simulates our normal pancreatic function, the basal insulin secretion. And when we take food, the pancreas secretes extra amounts of insulin. That is simulated by the that is similar to the bolus regime that we give. Bolus regime is either ultra short acting, namely the Lispro, the Aspart, and glulicin. These are the mainly three available in the market. And the regular comes as a short acting insulin. The peak is usually between 15 to 30 for the short acting, and effective peak 1 to 3 hours. That's why when you convert from an IV insulin to a subcut insulin, see, the peak is usually 1.5 to 3.5 hours, and that's why you have to give it 2 hours prior to stoppage of IV insulin therapy. And the basal insulin, we have to give it there are different types. One is intermediate acting and long acting. Intermediate are NPAs, that is a neural protamine hagedon. Usually the half-life is 4.5 hours, effective peak is 4 to 6 hours, duration of action is 12 hours. The longer acting ones are glargine, detamine, deglutec, and there is a newer molecule which has come, FC-TORA. This will come in the latest slide. So till date, we knew that the longest acting insulin is insulin deglutec, which has an action, or the action is more than 24 hours. And just notice this, glargine or deglutec, they don't have any peak at all. Your long acting insulin will never cause hypoglycemia unless patient is going into new onset sepsis or some other reason. So if your blood sugar is 100, you don't have to stop your long acting insulin. You can continue that. And similarly, you can continue giving long acting along with your IV therapy, IV regime during a management of DKA. Now, there is another trick that I want to carry forward to your students, that how to calculate the insulin requirement. When you are managing a DKA patient management is done. say post procedure or post admission day 2 or 3. Now the nursing staff asks that subcutaneous insulin we have to give, how much to give. So you have to first add up all the requirement in IV scale in the previous 24 hours. The 24-hour requirement, out of which 80% has to be substituted. So if your requirement in the previous day of 100 units, you give 80 units total in the form of subcutaneous insulin. Step number one. Step number two is divide this 80 insulin in 50-50. 50% should be long acting, 50% should be short acting. 50% is basal, 50% bolus. So you give around 40 units long acting like deglutide in the afternoon or in the night. If you're giving deglutide, it doesn't matter. You can give it anytime in the day. And the second thing is that you add a short acting. That short acting you divide three times, one third. So 40 units you have to divide three times. So you give roughly 13 units before lunch, before dinner, and before breakfast, before lunch, and before dinner. That's how you divide. But you have to keep in mind that ICU patients are kept at 2 hourly, 4 hourly intervals, and they're not routine OPD patients who will take 3 to 4 meals a day. So in these cases, we have to be a bit dynamic on our insulin management strategies. Initial dose of insulin, this is another trick, that even if your insulin requirements was say 100 units in the previous day, you might not require that high dosage, because in the initial period you require higher amount of insulin to break the insulin resistance. Once you have broken down, your requirement goes down. So if you don't know how much amount of long acting to add when you are converting from an IV to subcut regime, give a 0.2 to 0.3. So it's 60 kg, you give 12 to 18 units as long acting, and then monitor the sugars over the day and then titrate accordingly. And the recent update that has come is insulin APC TORA, that's given once per week. All we have read till now, the longest acting was insulin deglutide, which is given once daily, but this is given once per week. Surprisingly, it has shown similar glycemic control at 52 weeks, that's a year. But in the one parallel group, there was increased incidence of hypoglycemia, so it's the safety of which is still never not established. I'll now discuss 5 questions which are conceptual. Do I have the time? So I'll discuss 5 questions which will be over in 5 minutes. 5 questions, but they're conceptual questions. So I'll discuss those. The first questions, I'd like everyone to go through the questions. Fatma, or the moderator, do I take questions or queries now, or should I go to this question answer session? I guess that I'll just go through this quickly. So I will like to everyone to focus this. This is a conceptual question. This I have prepared myself this question. So just go through this question once. So 45-year-old diabetic female was on oral hypoglycemic agents. There was one big history of background history of some fever, loose stool. She has some irregular dietary intake, but as per the relatives, she was taking some oral hypoglycemics despite not taking her food. Now presented to the emergency with a drowsy state, there was acidotic breathing. You find that on the EBG, the pH, she is tachycardic, lower normal blood pressure 90/50, thready pulse, probably shocky state. Her ABG shows pH of 7.01, PCO2 of 24, bicarbonate of 9, sodium is 135, potassium 5.2, chloride 101, lactate 19. Sugars levels are 200, and urine ketones are positive. What is the next best step of management? Would you go for IV insulin, IV fluids, electrolyte management, anti-infective measures, or IV insulin fluids? You go for renal replacement therapy, RT lavage, and anti-infective measures, or you go for a renal function test, look for renal ultrasound, look for pyelonephritis, treat with antibiotics, or do an ultrasound abdomen and X-ray abdomen and give antibiotics. Any voluntary answers? Any volunteers for this question? Any volunteers? Yeah. So a few people have answered one. So the answer is not one. It's a tricky question. So the next entity. I purposefully put this question. So this can come as a some hard kind of question in entrance or competitive exam. Is an entity known as metformin toxicity. So metformin toxicity is when you have excessive metformin in your body by accidental overdose, or a patient who has other sepsis features, or patient is in shock but you still continue to give metformin. They will have reduction, they will damage the mitochondrial mitochondrial oxidation mechanism by blocking the cytochrome C, and they will decrease the oxidative phosphorylation pathway of the pyruvate. Just look at this. Normally, the glycolysis goes like the glucose to glucose 6 phosphate, and then pyruvate. Pyruvate is now oxidized by virtue of Krebs cycle to form NADPH plus H plus and the ATP molecules. If you block the mitochondrial chain by giving metformin, then pyruvate to this oxidation doesn't go. Pyruvate now in an acidic environment forms lactate. That's the usual lactate formation. So if you give metformin, this one is blocked. You give more rise to you give rise to more amount of lactate. So these patients land up in lactic acidosis. The three terms are there. Metformin induced lactic acidosis. That is when metformin itself is the sole cause of lactic acidosis, generally due to self-ingestion. Metformin associated. Supposedly, patient was on metformin but developed sepsis. Now lands up in lactic acidosis. So metformin per se is not the sole reason, but it's a contributory factor. And metformin unrelated, where metformin lactic acidosis is not the causative cause, a pure cause. So clinical features are hypothermic. Patient can be shocky. Patients has increased lactate. Obviously, lactates has to be very high. They simulate euglycemic decay. So they will have near lower or kind of normal sugars with the higher lactate and ketosis. The management usually is a GI decontamination by artery lavage and a mode of renal replacement therapy. During my DM entrance, the one question came, which of the drugs were dialysable? So one option was metformin, or so metformin is dialysable, so you can initiate renal replacement therapy, either an intermittent hemodialysis or continuous renal replacement therapy. Either way is fine. You have to manage the hypoglycemia part with IV dextrose. Metformin does not cause hypoglycemia. A toxicity cause hypoglycemia. You can give GIK drip to antagonizes the toxin actions. There is no, you have to give fluids for the management of lactic acidosis, but no fluid is superior to others. If you give normal saline, that will aggravate the acidosis. If you give ringer lactate, that will also aggravate the lactic acidosis because lactate is not utilized, metabolized in metformin toxicity. You can't give plasma light and all those because they will also have buffers which need liver metabolism, and that doesn't occur. There is some experimental role of methylene blue because methylene blue is a kind of an antioxidant which stabilizes the mitochondria. And when you go for extracorporeal therapy like this dialysis and all, if your pH is severely acidotic and lactates are very high, that's the basic two indications. The indications I put here, I'm not so important to remember mug up the individual. Now that revisit the question once. The important clues were patients was on oral hypoglycemic agents, and notice the lactates are 19. DK patients can have high lactates, but they will not have a lactate of 19. If your lactate is 19, there has to be some other disease process. There is higher non-gap acidosis. Everything is pointing towards a hagma. However, the lactates and the history of OHA intake points towards something else. So that's a metformin associated lactic acidosis or MALA. And the option right is 2. You have to go for management of DKA, IV insulin. IV insulin here, despite normal sugar, is given because insulin antagonizes the toxin action of metformin. It reduces the fatty acid breakdown, catabolism of the proteins and all. So it is given for other purposes. So not per se because of DKA. So IV insulin, and the choice is anti-infective we have to give because patient has a history of some kind of sepsis or some infective focus. Now this is a few questions, just quickly going through them. Regarding DKA management of the patient, which of the following is true? Statement 1, DKA can be diagnosed in a diabetic patient presents with RBS of more than 200 and bicarbonate less than 15. Then point number 2, which of the following? So it is, you have to tell whether it's true or false. Increased ketones means increased severity. It should be treated with a fixed dose insulin infusion. During management, subcut insulin is started if the sugars are controlled on IV insulin, usually 2 to 3 hours after the IV insulin, and the progression of the decay or management during management can be monitored by urine ketones. Any volunteers? Yes, someone has answered. So it's TT. The first one is false. Yes, so that let me clarify. First one is false because you need to have all the three criteria. You need to have a ketone positive to mark it as decay. So you have two criteria, so that's a false. The second one is true indeed. Ketones are do correlate with the severity of the condition. As I said, more than 6 is severe and more plus 3 is mild. That's why the chart that I mentioned is important. Should be treated with fixed dose insulin infusion again is true. It's not false. Because during DKA management, we don't follow the IV insulin, that is the VR triple I regime. VR triple is variable rate. we give zero point 0.1 units and then monitor the sugars, right? So the insulin infusion in DK is known as FR888, fixed rate insulin infusion, IV insulin infusion. So it's a fixed dose. That's a true. And during management, so obviously option 4 is false, and option 5 is obviously false. So few of them got it right. Now coming to the next question, which of the following are complications of DKA? Hypomagnesemia, cerebral edema, hyperphosphatemia, normal iron gap acidosis, and coagulopathy. So these are the options: hypomagnesemia, cerebral edema, hyperphosphatemia, NAGMA, and coagulopathy. So I'll just prompt it. So first one is correct. Hypomagnesemia occurs. It's similar to potassium. Magnesium will go inside the cells. Cellular edema, again true, because rapid lowering of sugars does cause cellular edema. Hyperphosphatemia doesn't occur. Hypo occurs. So that one is false. Option 4, normal iron gap acidosis. Yes, it is true, because in the resolving stage with AKI and use of normal saline, it can cause normal iron gap acidosis. Last one is obviously false. Sorry. Question number 4, with regards to glycemic control, which is true? Risk of mortality increases with variable sugars. Tighter sugar control at lower range is associated with better outcome in uncontrolled sugar patients. Nice sugar and Vicep trial show that IIT or intensive insulin therapy, that's 80 to 110 range, associated with better outcomes and reduced infection risk. Capillary blood sugar is the gold standard for the shocky patients, and sitagliptin associated with worse cardiovascular outcomes. Volunteers, question number 4. Just look at the question. I'll wait for 20 seconds and then I'll answer. Which of the following is true? Any volunteers? So I'll brush through this question. So, option 1 is true. Yes, increased mortality with increased variable sugars. I have discussed on the beginning. Tighter sugar control is better. Theoretically better. Tighter means it's 140 to 180 in patients who have a controlled sugar on the background. For diabetic patients, you will want a less tighter control. So this one option is false. Nice sugar and Vicep showed that intensive insulin therapy is actually harmful. So this is the reverse. So this is false. The capillary blood sugar is not the gold standard. Obviously, that option is false. And this is actually the fifth option is true. Sitagliptin, as per the trials, associated with worse cardiovascular outcomes. This is just a other kind of out of the topic question, but again, some factual things. And last question of the day: DKA versus HHS. Which of the following is true? I think every one of you will get it right. DKA associated with increased mortality than HHS. This is false. HHS more mortality. HHS typically have very high sugars, which is true. HHS require more insulin therapy, which is false. DKA requires more insulin. Severe dehydration and therefore enormous fluid administration is a hallmark of DKA. Again, is false. HHS require more fluids and more dehydration in HHS. And pH has to be acidotic in DKA patients presenting with vomiting. Can anyone volunteer? The last question of the day. So, the question number 5, option 5. pH has to be acidotic in DKA patients. So obviously it is not a mandatory thing. What disorder would you expect in a DKA patient presenting with vomiting? Last question of the day. What disorder will you get if you have a patient with DKA presenting with vomiting? Or what type of disorders you can expect? So DKA patients can have combination of multiple no, pancreatitis is that's a underlying factor. I am asking in terms of, it's my fault. I am asking in terms of blood gas analysis. So you can have a triple disorder. In DKA patients, you are expected to have a metabolic acidosis, that is high iron gap. But if you are having severe vomiting, that can lead to metabolic alkalosis because you are losing the hydrochloric acid from the stomach, and because of the underlying some other factors, so there is a metabolic alkalosis, metabolic acidosis, and patients being DK, obviously they will have some respiratory acidosis or acidotic breathing, compensated respiratory alkalosis, but they will not be adequate. So there will be 3 disorders present: metabolic acidosis, compensatory respiratory alkalosis, and the third one will be a metabolic alkalosis if there is vomiting. So that concludes the class. Any doubts that you have? I think it's over time by 10 minutes. Anyone have any doubt? Anyone ask any questions?
Aspirants, please, if you have any question, please you can ask now. Sir, I guess they don't have any question as of now. But if any question rises up, we'll be having the second class soon. We can
Oh,
discuss it during that.
yes.
Thank you, sir.